Yeah, so welcome to today's Decoding CTO session case 23. So today I'm bringing a case of right coronary artery CTO with uncrossable retrograde Corsair. I'm Dr. Sharath Reddy, interventional cardiologist, Medicover Hospitals, Madhapur. My case is a 66-year-old male. Came with existential angina class 2. He had old infeval MI and mild LV dysfunction. CAG was done showing a triple vessel disease with middle-lid stenosis, RCA mid-total occlusion and LCX distal total occlusion. CT angio showed calcium within the CTO in right coronary artery, and his eGFR was 78 ml, and he is diabetic and hypertensive. So this is coronary angiogram of left system. You can see there is a lesion, so kind of intermediate lesion in the proximal LAD, so just before bifurcation, and we can see in right coronary artery is filling from septal collaterals, so a big right coronary artery. Yeah, so this is a right coronary artery shot showing mid right coronary artery total occlusion. You can also see the origin. It is coming from anterior aspect of the sinus with the immediate downward course of the vessel. Yeah, so and we can also see this is the distal LCX. So distal LCX is totally occluded. There is a stent here, so from LCX to OM. This has been there for more than 5 years. That's during first procedure also. And this is ANTOMICOGRAM. So you can see this is a right coronary artery. So this is LAD. LAD, there is a donor. It's a donor vessel where there is a intermediate lesion, and there are good septal collateral filling right coronary artery. And right coronary artery is originating from anterior part of the sinus with a downward course after origin. And this is a mid RCA CTO with an ambiguous cap, and it's a long lesion, and there is an angulation. So here more than 45 degrees, and there is also calcium which is in almost JCTO of 4. Yeah, this is the collateralogram showing significant, moderate lesion in proximal LAD before septal collateral origin. So before crossing retrograde in this patient, most likely we have to address this lesion. So otherwise it is like a single surviving artery. Patient might get complicated during the course of procedure. So coming to the wiring strategy in this patient, so he had an ambiguous proximal cap, and there is an appropriate interventional collateral, and also his right coronary artery origin is quite anterior in the right coronary sinus with a downward takeoff, so which usually don't give immense support for antegrade wiring. So for that reason, I decided to go ahead with retrograde wiring first, and after retrograde wiring, then we can start antegrade wiring using retrograde wire as a marker. If you have enough support, it's fine, or otherwise we can do a reverse cut and complete procedure, so which I will show in subsequent slides. So this LAD pre-intravascular ultrasound before going retrograde. You can see this is the MLA of LAD at the site of lesion, around 2.9 mm square, and this is the distal reference, which is around 11 mm square. So it's clearly more than 70% area stenosis and 2.9 mm square MLA. So in such a situation, when I have to go retrograde, I would always address this lesion before going retrograde. Otherwise, we may end up in hemodynamic compromise during the course of procedure, and procedure will go unpredictably. Yeah, so we as there is circumferential calcium as shown in IVUS, so we went ahead with FLEXTOME 3.510 millimeter. So you can see here, so this is a circumferential calcium at the site of lesion, but it's very discrete, and you can see after FLEXTOME there is a good cuts within the calcium, and which you can appreciate in these IVUS videos too. So you can see this is a circumferential calcium, and you can also see, you know, how well see the FLEXTOME gave cuts into the calcium. So, and there is a good luminal gain after FLEXTOME. So then we went ahead with a stent, that is 3.5 and 23 millimeter stent, which got very well expanded. We can see in two orthogonal views, stent is expanded quite well. Then we proceeded with retrograde. You can see the origin of septal collateral, so it's a quite acute and going towards cranial part of the basal septum immediately after origin. So this poses challenge for wiring. So we took a double lumen catheter just to wire this septal. You can see, with double lumen catheter we entered septal with cyan blue wire. So once you enter, then you have to exchange the double lumen catheter and send your retrograde microcatheter. In this case it is Corsair 150 millimeters, and we took a septal angiogram. We have a straight septal which is CC2, and we crossed with Samurai RC wire in this case, but otherwise my choice of wire septal is Scion or CO03. As this is CC2, we could able to cross without much problem with Samurai RC, and you can see how well Samurai RC crossed septal collateral and went into PDA, and then we advanced Corsair into the PDA. So after Corsair reached PDA and distal RCA, so we did a Recce wire with fighter wire. So wherever there is a long CTO and with bends within the vessel within the CTO, it's always better to use a Recce wire, either fighter or fielder XTR. Do a Recce to understand the course of the vessel, then escalate your wire to Gaia 2 or Gaia 3, and you follow the Recce wire course with your Gaia 2. And Gaia 2 was stuck here, then escalated to Gaia 3. So again that was also stuck here. So then we escalated to Miracle 12. Miracle 12 advanced beyond the point where Gaia 3 was stuck, but it was not able to penetrate the proximal cap and get into true lumen. So this is when we decided to go ahead with antegrade wiring. You can see there is an antegrade amplerger catheter with a wire into side branch. So it's an anchor wire just to give support to the guide. We also placed a balloon just to get some support to do a kind of anchor balloon for antegrade wiring support. So we took a Harnett wire as Gaia 2, Gaia 3 were not entering proximal cap. We took 114 and advanced using retrograde wire as a marker. But you can see in the angled view, so both the wides are quite well separated in LAO, though they are overlapping well in RAO. So that is when we redirected wire, and then we tried advancing antegrade balloon over Harnett wire, but balloon didn't enter CTO lesion. So we couldn't do a direct reverse cart within the lesion, and we took a decision to go ahead with extended reverse cart subsequently, as the balloon was not entering into the CTO segment. So what we did, we took a balloon on this side branch wire. It's a 3 millimeter balloon, and retrograde wire is Gaia 2, and this Gaia 2 is directed towards the balloon. So this is an extended reverse cut done within the normal vessel. So this might lead to losing this side branch after PCI. As this branch was small, so we were not really concerned. So that's the reason we opted extended reverse cut. So with extended reverse cut, Gaia 2 entered into the proximal true lumen, and then we have sent GUIDELINER, guide extension catheter, so over antegrade wire, so to facilitate reverse cut as well as externalization of retrograde wire, and also it gives immense support to your antegrade guide. So you can see this Gaia 2 is into the antegrade guide now. After trapping retrograde wire in antegrade guide extension catheter, we tried advancing Corsair, but Corsair was stuck here. This is the point where Gaia 2 was stuck, Gaia 3 was stuck, and only Miracle could advance beyond this point. So that clearly says there is some kind of calcium spec sitting here, which is preventing your retrograde gear, going beyond that point. So we took a decision to do a tip-in, so in which once your retrograde wire is in antegrade guide or guide extension catheter, you advance a microcatheter. You can see this is the tip of the microcatheter, and you can see my retrograde wire is going through the antegrade microcatheter. So yeah, so once retrograde wire is into antegrade microcatheter, you advance microcatheter over retrograde wire, and that crossed lesion. So as the bias, wire bias to microcatheter is different from retrograde to antegrade, we can sometimes cross with antegrade microcatheter despite retrograde microcatheter is not crossing. So that's what happened. So once microcatheter went down, so we exchanged to a support wire. This is very important, go with good support wire. In this case we used Ironman wire because we don't have a good guide support in this case for your subsequent gear advancement. So and then we dilated with a 2 mm balloon, so and also 2.5 mm balloon. So you can see the vessel was opened nicely, and subsequently we stunted with 2 stunts from proximal to the distal RCA ending before the crux. So this is a RCA anatomy before intervention, and you can see this is after PCI. So all branches, distal branches are filling nicely, and as I already mentioned, this small RV branch, the flow is reduced because of extended reverse cut. So coming to the final IVUS areas, so it's 6.9 proximally with a block area of 54%, 6.5 with a block area of 45%. This is at the site of calcium, you can see, and this is where all the struggle happened, for retrograde wides as well as retrograde microcatheter. And yeah, the distillate is 6.4 with a block area of 38, and it is 4.4 with a block area of 38 at the distal stunt. So conclusions from this case are: Anamolous RCA origin with ambiguous cap poses greater challenges. Preemptive GUIDELINER usage facilitates antegrade wiring and also retrograde wire externalization and reverse cut facilitation. SEPTAL with acute cranial takeoff can be wired with double lumen catheter. Lesion uncrossability with retrograde microcatheter can be solved with following techniques. Take a talkable microcatheter if you have not used it upfront. Try microcatheter advancement with varying tension on retrograde wire while it is trapped in your antegrade guide to change the wire bias for microcatheter advancement. You can increase guide catheter support, that is retrograde guide support, for better talkability and pushability. You can use tip-in method for quick antegrade access in cases where you are not able to cross lesion retrogradely. You can also do clock modification on antegrade wiring by subintimal clock crush for further advancement. So you can subscribe to my YouTube channel, Interventional Strategies, to see more of such learning cases. Thank you.